All right. Thanks so much, Adam. And yeah, today we'll be tackling the differential for neck masses in infancy. I have no relevant disclosures, although I want to give a big shout out to a medical student I worked with on the initial abstract presentation that this presentation is, or that this lecture is based on. We submitted an educational poster exhibit to ASNR 25, which a lot of this work originated from and then has been expanded upon. But a big shout out to Jonah Joseph. He's going into radiology and going through the match this year. So best of luck to him. All right, so our objectives for today will be I'll present the key clinical and imaging characteristics for need to know neck masses that present during the first year of life. And I'll be dividing these into congenital, vascular, benign neoplastic, and malignant neoplastic lesions. As part of this discussion, I'm going to include important technical considerations to remember when imaging this patient population. And then as we discuss differentials, I'm going to try to do my best to highlight important imaging pearls and pitfalls to keep in mind. And before we jump into our discussion, I just want to show three unknown cases. Um, Marked unknown cases, especially the middle image, but we'll come back and revisit these common entities or not infrequently encountered entities at the end of my lecture. Okay. All right, so neck masses presenting during the first year of life do pose a diagnostic challenge for neuroradiologists and clinicians alike because of the small patient size, because there's rapidly changing anatomy, and also because of a potential for airway compromise, especially when lesions are large. Because of this, timely and accurate imaging of these lesions not only helps to differentiate benign and malignant pathologies, but also helps guide the acute and long-term care for these patients. Knowledge of the clinical features and imaging findings for these different imaging subgroups that can present in the first year of life help enable timely diagnosis, treatment, and then prognostication for patients. Before we jump into the pathology and the differential diagnoses, I just want to highlight some of the imaging modalities we have available or at our disposal and some of the important considerations for patients at this age. So as we know, ultrasound is going to be the initial imaging for most neonates because it is non-invasive, it's portable, and it provides a real-time imaging evaluation without the need for radiation. Doppler is also going to be incredibly helpful to assess for internal vascularity. Some limitations, as we're all familiar with from our training, these can be tech dependent, and there's often a limited assessment of the deep neck spaces, which leads us to CT. So CT will often be performed to get a better look at an improved look of the deep neck spaces without the need for sedation. It's a more rapid acquisition, as we all know. And CT also provides the added benefit of providing a look at the adjacent osseous structures. Is there any internal calcifications that can help us hone the differential? Important limitations to keep in mind for this patient population is the presence of ionizing radiation for these exams, and especially in young neonates and young infants, we don't always get the best look by low-dose CT of the deep neck soft tissues. So that is an important, especially if you have older scanners or if we're really sticking to these low dose protocols, it can be really hard to see along the cervical lymph nodes. So that is an important caveat to keep in mind, and certainly an improvement that MRI provides in the assessment. So again, MRI is going to provide us improved soft tissue assessment, not only looking at the lesion itself, but also the adjacent soft tissues and involvement of adjacent soft tissues, and then giving us a better look at those deep neck spaces. In terms of because again, we have multiple sequences to help with characterization that can improve our assessment of malignant potential, et cetera. And importantly, in contrast to CT, there's no ionizing radiation, which we love for our infant patients. There is a longer acquisition time, as we're all familiar with, and so often we do have to give sedation for these patients to be able to get diagnostic imaging, especially if we are going to give contrast, which is often needed for the assessment of neck masses. Because of the small, moving on to infants themselves and some technical considerations, because the patients are small, there is a focus on high resolution imaging to assess the masses, but that is another diagnostic challenge for radiologists and technicians alike. Um, as I just mentioned, imaging in babies can be motion degraded, and so we can use sedation to help minimize the motion artifacts, but also feed and swaddle techniques can sometimes be successful, especially in the first couple weeks to months of life. Even with contrast, we've had success at our center doing that, but won't work for all patients, and then sedation may be required. Rapid MRI sequences are on the rise across all centers, and so hopefully that'll improve how we image these patients in the future, and as our motion correction software techniques. One important consideration to keep in mind when imaging all of these patients, especially when there's a large lesion that's under assessment, is be very mindful, especially if sedation is going to be done, coordinate with anesthesiology. There should be multi-care discussion about how patients are going to be imaged, patient positioning, again, just important to preserve the airway and avoid obstruction. Just a couple pointers about ultrasound and MR and CT. Be careful about probe selection or be mindful of that. High frequency linear probes are going to be good for superficial masses, whereas we'll use low frequency probes for soft tissue assessment in the deeper structures. In terms of contrast, um, really contrast is going to help improve the quality and the assessment for both CT and MR. But I would say with MR, when you add fat saturation techniques, this provides an improved assessment for any neoplasms, vascular lesions, congenital pathologies, and superimposed infections. You'll be able to see better delineation between the lesion and adjacent structures and the extent of lesion as well. Okay. Okay, so moving on to our differential, we're going to begin with congenital lesions, which I think all comers is going to be what we most commonly encounter in a clinical practice. And we'll just be marching through the differential, beginning with branchial cleft anomaly. So first, branchial cleft cysts. So this is going to be any mass, cystic mass near the EAC, parotid, or the pinna. Patients may present with otorrhea, recurrent parotid space abscesses or infections, or the clinician may say that they see a sinus tract or a cutaneous pit on physical exam. Pathogenesis-wise, this lesion is a remnant of the first branchial apparatus. We can subdivide the lesions into work type 1 or work type 2 lesions. Work type 1 are going to be lesions that are going to be near the pinna or the EAC, and then work type 2 lesions will extend from the EAC toward the angle of the mandible. And kind of keeping that localization in mind helps pick up lesions, especially the small ones that come through in daily clinical practice. On imaging, I have some MRI images here from a 6-month-old who presented with a left cheek fistula. But on MRI, we will see a periauricular, as in this case is pointed to by the arrows, or a periparotid cystic lesion, or a fistulous tract, or a sinus. These lesions can be hard to identify, or these lesions can be hard to identify by imaging. So MRI really is going to be the best modality to help identify these subtle, often what I find subtle lesions. It's also one of the helpful MRI tips that especially our ENT surgeon always asks is there any adjacent parotid involvement? Does that look inflamed? Was there prior inflammation? Because that's going to help with his surgical planning to help prevent recurrence of these lesions. All right, because he'll usually take a cuff of the parotid if involved. In terms of complications, especially with work type 2 lesions going towards the angle of the mandible, there is a risk of facial nerve injury during resection. Truly, and going back to my clinician's questions about where is involvement, is the parotid involved, he wants to make sure he's resecting the cyst tract and fistula in entirety to prevent recurrence. So our goal of imaging is to make sure that we delineate full extent to help improve surgical outcomes. All right, moving on to second apparatus cysts. So these present as painless lateral neck masses anterior to the sternocleidomastoid and posterior to the submandibular gland. Patients can present with recurrent infections or skin drainage. These are remnants of the second branchial apparatus. On imaging by ultrasound is shown at screen right. Lesions will look hypoechoic to anechoic with a thin walled surrounding a cyst. Um, Commonly, in the absence of infection, you shouldn't expect any associated vascularity. By CT or MR, you'll see a cystic lateral neck mass anterior to the SCM. And again, you can see inflammation if the structure is inflamed or infected at the time of imaging. Complications to keep aware of. Patients are prone to getting recurrent infections. These lesions can be a mimic for a cystic neoplasm or an abscess if they're infected at the time of imaging. So just something to keep in mind. If you do find these lesions, or if you do have an abscess that presents in clinical practice through the ED, for example, get follow-up imaging till resolution to make sure there is an underlying branchial cleft cyst. Okay, and then going back to same is true for branchial cleft type second apparatus cyst, just like the first. You need complete resection to prevent recurrence. So getting the full extent of lesion is important, especially looking for an associated tract. All right, moving on to third and fourth apparatus cysts. These patients present with neck swelling, recurrent thyroiditis, an abscess associated with the thyroid gland. They can have painful deep neck space lesions if they're infected. And then in general, all comers, these lesions tend to be more common on the left. These lesions are remnants of the third and fourth branchial apparatuses. Patients can have sinus tracts and fistulae as well. On imaging, in truth, it's hard to always truly differentiate between third and fourth apparatus cysts. What we can see on imaging are deep neck space cystic lesions in the anterior lower neck or upper posterior triangle. Any suggestion of a tract that communicates from the piriform sinus on the left down towards the left thyroid gland is also suggestive. But truly, it is hard to differentiate these lesions. So fair to give a differential or to name both if you see an abscess, for example, communicating between the piriform sinus and the thyroid gland. Sometimes oral contrast can be helpful too to see that tract, that communicating tract. So here, this ended up being a type 3, but a large cystic lesion centered in the midline neck at most levels, superior and inferior. This ended up being a type 3. Lesions are prone to infection. When large, as in this example, prone to airway compromise. In the example I'm showing here, you can see that it's laterally deviating the airway. And certainly complete resection is going to be important, just like the other cysts, apparatus cysts, to prevent recurrence. Okay, so moving on to ectopic thymic cysts. These are often small and asymptomatic, but when large, they can cause stridor and dysphagia and can be more palpable on physical exam. Sometimes patients will present for concern for neoplasm. Pathogenesis, these are remnants of the thymopharyngeal duct, which is a third laryngeal pouch derivative. On imaging, you can see various things, but a cystic lesion anywhere from the piriform sinus down to the anterior mediastinum. If it looks more solid, look for imaging characteristics that look like normal thymic tissue. Commonly, as in this example, there's involvement of the left infrahyoid neck. Often there is involvement along the carotid sheath. And the lesions tend to be pliable and they'll kind of conform to the adjacent neck structures. And I've shown in the screen left image, a very classic imaging appearance is going to be this band of tissue that connects the thymic cyst structure with the normal thymic tissue, okay, in the mediastinum. So that's a classic appearance. And here, this image at screen right is just helping show that association with the carotid sheath. Okay. Complications to keep in mind, mass effect, associated mass effect when large, And then this is a mimic for neoplasm. So just be aware of the common imaging features, that pliability, that band of tissue, and that helps differentiate this on imaging from a neoplasm if you're not picking up that normal thymic tissue appearance. Okay, moving on to foregut duplication cyst. This is a midline paramedian neck mass. A common location, which is not shown here, but a common location would be in the midline oral cavity anterior tongue region. Um, Patients can present with dysphagia or anterior displacement when they're large, or airway displacement when large. These lesions are derived from the foregut. There's an unclear pathogenesis in terms of, but some of the theories in terms of where these come from are split notochord, faulty recanalization, vascular compromise, etc. On imaging, ultrasound can be helpful for picking up the characteristic gut signature of the cyst wall. On CT, oftentimes we see a nonspecific cystic structure. They may be oval, round, or tubular in morphology within the anterior paramedian neck. And admittedly, as shown, admittedly, like the case I'm showing here at screen right, when these lesions are large, it's hard to know where they're coming from and what they're involving. For example, was this case involving the thyroid? It's certainly displacing it. But again, any lesion any large lesion in a baby can be hard to further characterize. MRI can help with some of that, but this ended up being a pathology diagnosis. And then complications. Truly, there shouldn't be many if you get complete resection. Okay. Moving on to lingual thyroid. This is a midline tongue-based mass. Patients present with dysphagia, dyspnea, or sleep apnea. And infants, in particular, can present with congenital hypothyroidism, which was the case for the patient whose imaging I'm showing. So pathogenesis, these lesions come from arrested thyroid descent, which occurs somewhere between the third and seventh gestational week. Thyroid tissue, thyroid tissue will be somewhere in an abnormal location along that expected pathway of descent. 75% of patients, it's important to keep in mind, will not have an orthotopic thyroid. So that's important. That's an important thing that you'll be looking for in imaging before these patients undergo treatment. On imaging, by CT, for example, you'll see a well-defined enhancing or hyperdense mass that's going to be at the midline base of tongue. By technetium scan, we'll see uptake. The uptake is going to come from the locations of thyroid tissue. So is it in, do you have an orthotopic gland, and where is the ectopic thyroid? So the image here I'm showing at screen right, the arrow is pointing at the lingual thyroid. And then the dotted circle is pointing to where you would expect the orthotopic thyroid to be if it had been present in this patient, which it was not. Again, this was a 7-day-old who presented with congenital hypothyroidism. Complications to be aware of, and these patients can get rare carcinoma associated, and it's again just important to keep in mind that you look for that orthotopic thyroid by imaging before the patient goes for surgery, so that they know if the patient will have residual thyroid tissue or not. All right, moving on to thyroglosal duct cysts. These are midline paramedian neck masses that will sometimes classically move with as the tongue moves. When these lesions are large, patients can present with dysphagia or breathing difficulties, and superinfection is also possible, like with other cystic lesions. Um, Thyroglossal duct cysts come from incomplete evolution of the thyroglossal duct, and then persistent secretions from the epithelial cells form this kind of cystic component within the remnant duct. On imaging, I'm showing an example, a subtle example that we picked up incidentally at screen on the left image. You're looking for an anterior midline cystic lesion within the suprahyoid neck or at the level of the hyoid. And then within the infrahyoid neck, it can be in a paramedian location. But it's going to be, these lesions can occur anywhere from the foramen cecum to at the base of tongue down to the thyroid gland, anywhere along that expected descent course. Again, when large, they can cause symptoms. Uh, Complete resection is important of both the cyst and tract to prevent recurrence. Um, they can get rare papillary carcinoma in older patients, and then an important imaging mimic. It's at the image at right is showing a follicular cyst, which can happen in the same location, but different underlying pathophys. But so screen left thyroglossal duct cyst and screen right is going to be a follicular cyst. Okay. So moving on from congenital lesions, we'll next talk briefly about some vascular malformations that can present in the first year of life. Beginning with the one we see most commonly, lymphatic malformation. So these are soft compressible masses that are often present at birth, and they may enlarge with infection or hemorrhage, as we see commonly in clinical practice. These are slow flow vascular malformations of dysplastic lymphatic channels. And on imaging, often the babies that present with lymphatic malformations will look very similar to the case I'm showing here at screen right. Um, so on ultrasound, it'll be a hypoechoic compressible mass with minimal Doppler flow. By MRI, as shown here, it'll be a transbasal T2 hyperintense cystic lobulated mass. There's multiple fluid levels that we can see as this fluid layering T2 hypointense signal within the cysts. Also on T1, you can see it here posteriorly. The cyst can be macrocystic or microcystic. Macrocystic lesions, I think, are a little bit easier to characterize. The microcystic can be challenging because the cyst walls can end up mimicking solid enhancement and helping kind of or makes the imaging characterization a little bit more challenging. But if we see solid enhancement or phleboliths associated with the lesions, you want to think about something along the venous malformation or venolymphatic spectrum of pathology. Okay, and then recurrence is possible if you can't completely resect these lesions, especially when large. Sclerotherapy is another option for treatment. Um, uh, as well. And then again, going back to the microcystic lesions can mimic solid enhancement and mimic neoplasm. So just an important component or imaging appearance to keep in mind during your evaluation. Okay, moving on to our next vascular malformation, we're going to talk about arteriovenous malformations. So these are, as you would expect anywhere else in the body, pulsatile masses with an associated bruit on physical exam. They can have skin ulceration or discoloration. Um, and then these can be present at birth and may enlarge with patient growth or with internal hemorrhage. Um, these are congenital high flow vascular malformations with AV shunting through a vascularitis, as we all learned in medical school. On ultrasound, it can be helpful, especially if it looks more mass-like, like the example I'm showing here at screen right. Ultrasound can be help confirm that there's high flow, turbulent flow within the lesion that to suggest something vascular in nature. MRI and MRA can give us a better characterization of the lesion as well. So it can look mass-like, but really take care to look for those prominent feeding arteries and draining veins that you would expect to see. So in the example I'm showing here in the middle image, we can see that there, and I should say in the CT, you can see it as well. There's some prominent adjacent draining veins associated with the lesion to at least raise the possibility that this could be a vascular malformation. As we all know, DSA is going to be the gold standard for assessment and treatment, and so we can better see the nidus, which I'm pointing to in the lower image. Yeah, this was just to give a history. This was a 16-year-old with left facial swelling. Okay, and then complications, much like AVMs in other locations, bleeding. Because of the AV shunting, you can get local tissue ischemia, so helping to explain some of that skin or ulceration you can see on physical exam. It's important to remember the syndromic associations with AVMs. So, any young patient with an AVM, HHT or hereditary hemorrhagic telangiectasia or cavernous malformation AVM syndrome should be considered, or at least syndromic associations should be thought of, especially in these young patients. Okay, so moving on to benign neoplastic and tumor-like lesions. We're going to talk about first congenital hemangioma and infantile hemangiomas. So I've broken them down into, we'll talk about each entity separately as we walk through this differential. So for infantile hemangiomas, these patients present in the first few weeks of life after birth. Lesions will grow rapidly in the first few months of life, and then they involute over time, beginning within 1 year of age. For congenital hemangiomas, in contrast, these lesions should be present at birth. They do not proliferate, and then they can either be rapidly involuting, partially involuting, or non-involuting in subtype. Pathogenesis wise, infantile hemangiomas are going to be GLUT1 positive, and congenital hemangiomas are GLUT1 negative. Both entities are vascular tumors, so not vascular malformations like we just talked about, but vascular tumors. On imaging, they can have very similar imaging appearances. So on MRI, we'll see a circumscribed T2 bright, light bulb bright mass with internal flow voids, as I'm shown here at screen upper right. And then avid enhancement is shown here at screen lower right. On ultrasound, you should see diffuse hypervascularity, no true turbulent flow to suggest an AV shunting lesion, but just very vascular lesions. Okay. And then another important thing to keep in mind is while the parotid location is very common for hemangiomas, as I'm showing at screen right, subglottic hemangiomas or airway hemangiomas are another important type of hemangioma to keep in mind. This patient at bottom left presented with it was a 10-week-old who presented with continued difficulty breathing and biphasic stridor. They went to bronchoscopy and they found a lesion. And so we followed them with MRI as we were trying to treat them with propranolol at our center. In terms of hemangiomas, all comers, when you have multiple hemangiomas or segmentally located hemangiomas, you want to think about some syndromic associations such as Fay syndrome, especially with the subglottic hemangiomas as shown here, but other airway hemangiomas. Another important complication to keep in mind is potential airway obstruction with hemorrhage or growth of the lesion. So those lesions in particular will require therapy with propranolol. And propranolol, just to highlight the difference between infantile and congenital, propranolol is usually treated for the infantile hemangiomas. Okay. Moving on to fibromatosis coli, a lesion we all learned about in medical school. So this is a painless pseudomass that presents in neonates or very young infants. Patients can have torticollis, and then often it's going to be on the right. This is a non-neoplastic enlargement of the sternocleidomastoid with associated fibrosis, and this can be secondary to in utero malposition or birth trauma. On imaging, ultrasound is truly the imaging modality of choice, and MR and CT are reserved for atypical presentations. But on imaging, you'll see fusiform enlargement of the sternocleidomastoid. The muscle fiber should be intact, and there shouldn't be any abnormal adenopathy and very minimal associated vascularity. So those are the typical imaging features that should be more reassuring that this is in fact fibromatosis coli. If patients do have adenopathy or if the mass persists despite physical therapy, those patients can go on to get an MRI for further characterization of the lesion. But truly, this should be self-limiting, often regresses by 8 months of age with physical therapy and stretching. Okay. All right. So moving on to infantile myofibroma and myofibromatosis. Um, Infantile myofibroma is going to be a solitary benign fibrous tumor that occurs in infancy most commonly. And the head and neck is a common location of involvement. There is another related entity called myofibromatosis, which is going to be a multicentric, similar looking lesions, but multicentric and with visceral involvement possible. Um, so kind of a spectrum. Infantile myofibromas are often secondary to sporadic mutations. There are some rare mutations in Notch3 and PDGFRB that have been associated as well. So more coming down the pipeline related to that. In terms of imaging findings on ultrasound, infantile myofibroma should look heterogeneous, hypo to isoechoic in echogenicity. Often, like, internal calcification is commonly seen, and there shouldn't be any internal vascularity. So, this is a common, nice imaging appearance for what you would expect to see. We see the calcification here, um, slightly hypoechoic mass, and then no vascularity. This patient did have lesions, had another lesion that was identified in one of their extremities. And they went on to get a CT for further characterization, and they had multiple lung lesions, a couple lesions in the abdomen, and then there was a retroperitoneal lesion here, is shown at the on the right. So this is a case, I'm showing you here, a case of myofibromatosis with visceral involvement. So infantile myofibromas or myofibromatosis without visceral involvement can spontaneously regress. When you have visceral involvement, obstruction or organ compromise becomes possible. So because of that, these patients will undergo low-dose chemotherapy. So the patient I'm showing underwent methotrexate treatment to help with their to help improve their disease. Okay. Moving on to fibrous hamartoma of infancy. So this is presents as a painless, firm subcutaneous mass that will often present during the first year of life. More common locations will be within the axilla, the trunk, or the upper arm, but head and neck presentations have been reported, and it has a male predominance. These are benign soft tissue tumors that on pathology have a triphasic morphology. So they'll be fibroblastic fascicles with fat and primitive mesenchyme on evaluation. On imaging, so the imaging for the case I'm showing was for a 12-year-old who had a suspected lymphatic malformation, but that just kept growing, and so that's why they did the MRI or the ultrasound MRI assessments for this patient. So on ultrasound, beginning with that, it can have this very characteristic, these lesions have this very characteristic multiple semicircular pattern. I think we can kind of appreciate that from the image I'm showing here. It has these echogenic regions with intervening hypoechoic bands. On the MRI, often you'll see a lobulated mass that contains T1, T2 bright fatty tissue, and T2 hypointense striations intervening with it. There can be irregular peripheral enhancement as well. But you can appreciate, especially looking at the T2, you can appreciate that T2 dark signal suggestive of an underlying fibrous component. Recurrence is possible with these lesions if incompletely excised. They may grow aggressively, locally, and aggressively, as was the case for this example, but not truly a malignant lesion, but just locally invasive. Okay. Okay, so moving on from fibrous lesions, we'll talk about plexiform neurofibroma next. So these are pliable infiltrative masses. They talk about the bag of worm texture that you can feel on physical exam, and these are seen in the setting of neurofibromatosis type 1. Admittedly, diagnosing a plexiform neurofibroma, which may be more apparent in older patients and adolescents, it can be challenging during infancy, at least on physical exam. pathophysiology, we see these in the setting of NF1. Because of the underlying NF1 mutation, patients are prone to getting cellular proliferation and tumor development, including plexiforms. Plexiforms or neurofibromas are going to see in about 30% of patients with NF1. There was one report that looked at plexiform neurofibromas during the first year of life, and they found that about 13% presented during their first 6 months in their cohort. So it is possible for them to present early, although do tend to be more subtle than we would expect to see in older patients. The case I'm showing here, is very classic. So we see a T2 hyperintense lobulated mass, admittedly still small in this very young patient, but in a classic kind of periorbital location. And then in terms of, I guess, because of the subtle in an infant that imaging can be subtle, the imaging findings, it's important to look for the other features of NF1 when evaluating any patient or making sure you finish your search pattern. So in this patient, we see other evidence of NF1 that helps us be more confident of our diagnosis. So I'm pointing to bilateral optic pathway, fusiform enlargement of the interorbital optic nerve, suggestive of optic pathway glioma bilaterally. When you have interorbital optic glioma is very characteristic of NF1. And then if we look at the deep gray structures, we see myelin vacuolization, so kind of patchy T2 hyperintense signal that isn't quite fitting the normal pattern of myelination you would expect for a patient of this age. This is a 9-month-old. So always going back to your myelination atlas if you're not sure to help know what's normal and not normal for a patient's age, I think is super helpful, especially when you're evaluating a mass, a head and neck lesion. Um, okay. And then not so much in infants, but especially in older patients, there's a 5 to 10% risk of malignant transformation as well. Okay. And then last entity we'll talk about in this differential will be teratomas. So these can be mature or immature. Um, on physical exam or in presentation, it'll be a large anterior neck or facial mass. Often when large, these will be diagnosed prenatally, and unfortunately, they can have rapid growth after birth. These are congenital germ cell tumors. Often mature teratomas are the more common subtype, and they can, as would be expected, they have contained tissues of all three germinal layers. On imaging, by ultrasound, you'll see a complex cystic and solid mass. By MRI, as shown at screen right, you get a better appreciation of that complex lesion. You see some cystic components as well as some soft tissue components associated with it. The prenatal MRI is also important to help assess for area displacement, helping to facilitate delivery, planning, as well as surgical planning after birth. When large, airway compromise is always going to be a concern, as well as mass effect on major vessels and adjacent structures. Okay. So while less common than the other things we've talked about, I do want to touch on malignant neoplastic lesions. Just we always want to make sure we round out our differentials and remember we're thinking about things that are concerning or and could have poor implications for the patient. So we're going to start with neuroblastoma. This is a common tumor in infants less than 1 month of age, all comers. I would say that in the head and neck, it's more likely that we'll see metastases from neuroblastoma rather than primary neuroblastoma itself. Patients present with elevated urine catecholamines. We learned that in medical school, but they can also present with Horner syndrome, so ptosis, meiosis, and anhidrosis, a palpable mass, as well as raccoonitis or proptosis. In terms of raccoonitis, that'll be secondary to metastases involving the orbital walls or orbital region, and it causes that associated bruising-like appearance, or periorbital ecchymosis or bruising-like appearance. So these are malignant neural crest-derived tumors arising along the sympathetic chain or anywhere along the sympathetic chain. If you have MYC amplification, that's an important feature to keep in mind when assessing these patients and their prognosis. On imaging, we'll see a heterogeneous enhancing mass that can have intraspinal or thoracic extension depending on where in the head and neck it's located. If you do have a CT, that can be helpful for looking for that hair on end periosseal bone appearance. Um, and then for MIBG imaging, it's going to be important for diagnosis, for staging, and then for follow-up during treatment. And we'll see avid enhancement anywhere where adrenergic tissue um, is present. Important thing to keep in mind, all comers is metastases are going to be more common in the setting of neuroblastoma at the time of diagnosis. About seen in about 50 to 60% of patients can involve the marrow, lymph nodes, liver, soft tissues, etc. And then a helpful point, and just going back to what I said initially when we were talking about MRI and assessment of these patients, fat saturation technique is really helpful for post-contrast imaging to help delineate the extent of the lesion and differentiate it from adjacent structures. Um, okay, and then going back to the MICAN amplified lesions, those have an unfavorable prognosis. So part of what reason why we look for it on pathology on the pathology assessment, and then also metastatic at the time of diagnosis. All right, moving on to rhabdomyosarcoma. These account for about 40% of these will be in the head and neck. Um, Remembering that rhabdomyosarcomas are going to be the most common infantile soft tissue sarcoma we see in clinical practice. We can divide, in terms of lesions involving the head and neck, we can subdivide the lesions by orbital, parameningeal, or involvement of other head and neck locations. Parameningeal meaning middle ear, nasopharynx, paranasal sinuses, or nasal cavity. Um, the other, especially in the infantile or the infant population, we're more likely to see involvement of other locations. Um, Pathology wise, these are high grade, small, round blue cell mesenchymal tumors. They can be embryonal, boytroid, or spindle cell in subtype. During the infancy, those are the common subtypes we see. The spindle cell has a favorable prognosis. On imaging, MRI is going to be most helpful for picking up the extent of these lesions. We'll see a T2 hyperintense mass that's heterogeneous, either from necrosis or from associated underlying hemorrhage. There can be enhancement. Classically, there's diffusion restriction. Um, I will say that rhabdomyosarcomas, much as in other patients in the pediatric population, while we like to see osseous erosion by CT, as is true in the case I'm showing here, or diffusion restriction by DWI, not all patients or not all pathologies will follow those rules of thumb. So there should always be an index of suspicion to rule out a common pathology. All right, so. Just taking a closer look at the imaging, I'm shown the here upper images are CT, the soft tissue, we can see that it's enhancing kind of heterogeneously. And then there's erosion of the adjacent zygoma. And by MRI, we can see that the lesion by T2, and then we see adjacent lymphadenopathy at lower screen right. PET CT is going to be important for staging, and any tumor involvement would be expected to be hypermetabolic. Okay. Um, if patients do end up having, especially for lesions closer to the skull base, if there is intracranial invasion or meningeal enhancement associated with that, those hold worse prognoses. Metastases, such as in this patient with lymphadenopathy, that also holds a worse prognosis. Okay, moving on from rhabdomyosarcoma, we're going to next talk about infantile fibrosarcoma, another important entity to remember in infants, in the infant population. So infantile fibrosarcomas are going to represent 5 to 10% of all infantile sarcomas. And then a subset of these will occur in the head and neck location. These present as rapidly growing, large, painless masses. The imaging I'm showing here was for a 4-month-old with an enlarging mass for 3 weeks. Um, these are malignant spindle cell neoplasms, and there's no predisposing factors to this pathology. On imaging, you'll see a heterogeneous hypoechoic hypervascular mass by ultrasound. And sometimes these can be picked up during prenatal assessments when large. On MRI, you'll see a heterogeneously enhancing mass, T2 hyperintense, and there's usually associated necrosis, which is pointed out by the asterisks at the lower image. There can be associated hemorrhage, diffusion restriction with it, as would be expected with malignant lesions. And MRI is important to characterize the full extent of the lesion and involvement of associated structures for treatment purposes. Um, Thankfully, infantile fibrosarcomas have a better prognosis than adult fibrosarcomas, and they have improved survival and lower metastatic risk with as long as we can achieve complete resection. Okay, and then just kind of rounding out the differential, we don't see lymphoproliferative disease very commonly in the head and neck in infancy, but I include this for completeness. Um, can present lymphoproliferative disease can present as a painless neck mass with lymphadenopathy, or the patient may have systemic symptoms as well. It can be myeloid proliferation, is going to be more common in the first 2 years of life. That said, the imaging I'm showing here is for a 9-month-old who presented with right neck swelling, and they had ALL with left cervical and parotid gland involvement. Um, okay, and then on imaging, on ultrasound assessment, if there's lymph node involvement, there'll be replacement of the normal HILA expected. Lymph nodes will look bulky by CT or MRI, and they may or may not have necrosis. MRI is also helpful for looking for more systemic involvement by lymphoproliferative disease. So look for abnormal marrow replacement as well as CNS or extranodal involvement, such as in the tonsillar tissues. Okay. Much like any other lesion in the head and neck, there can be associated vascular airway compromise. Because of the underlying immunocompromise of these patients, they are at increased risk of infection, especially atypical infection. So important to keep in mind when completing your imaging assessment. And because they have abnormal cell counts, they also have the known predisposition to bleeding. Okay, so whirlwind tour of the differential, but I just want to highlight a couple key imaging pearls and other things just as we close. So for ultrasound, keep in mind that this is going to be the first imaging assessment for superficial vascular lesions. These are portable, real-time, and non-invasive, which we like for our these young patients. MRI, though, is going to be best for looking at deep neck space involvement and further characterizing the complexity of lesions. Importantly, there's no ionizing radiation associated with them, but it does require sedation. CT will be helpful for looking for associated mineralizations, osseous involvement, and then CT may be desired over MRI if there's a concern about airway compromise as well, despite the radiation exposure. Moving on to diagnostic pitfalls to keep in mind. When you have an infected cyst that presents, remember that there could be an underlying lesion and get follow-up. And also keep in mind the patient's age and the location of the lesion as you make your assessment. Remember that some lesions in the head and neck can be malignant as well. So consider that in clinical context, get follow-up imaging or further assessment. And then when large, remember that these lesions can cause airway compromise, and you should optimize patient positioning during imaging, whether it's CT, MRI, etc. A few final tips to keep in mind. Consider the lesion location, the patient age, and then the imaging pattern to help hone your differential for these patients. Remember to keep in mind syndromic associations like FACE and NF1 to help fully complete the evaluation for these patients, recommend follow-up imaging, and to look for associated morbidities that will help direct patient management. And then, especially for large lesions, remember to collaborate with ENT colleagues to help optimize the treatment and surgical plan. Okay. Um, Here's the broad differential of the entities I covered in this lecture. And then I just want to go back to the unknowns I initially showed you. So at screen left, we have a T2 hyperintense lesion in the left neck. We see this thin band of tissue that connects it to the mediastinal thymus. Um, and in the middle image, we have this complex, partially cystic and solid mass, abnormal facial mass at midline. And then at screen right, we have this heterogeneously enhancing central necrotic lesion in the left parotid region. So ectomic thymus on the left, teratoma, and then infantile fibrosarcoma. Okay. Okay, and then here are my references, my many references. And then one before I close, I just want to give a plug for the upcoming ASPNR 26 annual meeting in Tampa, Florida. It's happening January 16th through 18th of next year. It's going to be a fantastic meeting. Adam and I are both on the program committee, and it's going to there's a lot of hard work going into the meeting. It's going to be fantastic. So please join. Abstract submissions close at the end of the month, so please submit an abstract and come join us in sunny Florida. And thanks everyone for your attention.
That was incredible, Sarah. Yeah, thanks for the shout out for ASPNR also. And yeah, if anybody is going to submit, we extended the abstract deadline if people haven't seen till the end of the month. So there's still a lot of time to put something together. And I think it's going to be a lot of fun and very educational. That was incredible. I think I'm gonna have to rewatch it just to, to fully absorb everything. If anybody has any questions or comments, please put them in the chats. Um, are you guys doing ultras? Are you reading your ultrasounds also, or is it the body
So,
folks who are reading it?
it's a weird grandfathered in division, but
Okay.
yeah, for all studies, right? But yeah, no, body reads the ultrasounds. Most ultrasounds, we read some of them, but not for the head and neck lesions.
Okay.
Yeah. What are you guys doing there? Do you have to read ultrasound?
No. I always walk across the room and ask them to go over the ultrasound too, and whenever we get the follow-up studies. So
Yeah,
yeah.
I mean, I think the cross division collaboration, it was nice so you can talk about cases and learn from each other. Yeah.
Yeah, definitely. Any questions, comments? Usha gave a clap. Thanks. Yeah, if there's no more questions, yeah. Thank you so much. And we'll see you at ASPNR. Hopefully see everybody at ASPNR and hopefully see everybody next month for next Peanuts talk also. Well, thank you so much.
Thanks, everyone.